Hello, everyone. Welcome and thank you for joining me today to view my presentation. My name is Dage, and I am currently a psychiatric mental health nurse practitioner, PMHMP student at South College. I am excited to share my synthesis project with you all. My project focuses on a very important topic. This topic is often overlooked. The topic focuses on medication adherence among incarcerated individuals in correctional health. So, the title I gave this project is Improving Medication Adherence in Incarcerated Individuals Through Nurse-Led Health Education. So, why did I choose this topic? As a nurse working in correctional healthcare, I have personally observed how many incarcerated individuals struggle with chronic conditions. They struggle with chronic conditions like hypertension and diabetes, but they often don't follow through with their medications. So, this can lead to serious health problems, unnecessary hospitalizations, and increased cost. Not just for these patients, but for the entire healthcare system. In this presentation, I'll walk you through the evidence I found and how nurse-led education can truly make a difference in this setting. I'll also explain my research process, findings, and the proposed plan to implement this change using a structured model and measurable outcomes. So let's dive into this. So you must know that incarcerated people often have complex healthcare needs. Many of them suffer from chronic conditions such as diabetes and hypertension, and even mental health disorders. Yet, medication adherence remains very low. Why? This happens because incarcerated individuals often don't understand what the medication is for. They take medications that they do not know anything about, or they mistrust the system. To address this, I asked a pickle question to guide my evidence search. Among so the question I asked is among incarcerated individuals with chronic conditions, how does nurse-led health education compared to standard care affect medication adherence? So, to briefly explain this PICO question, among incarcerated individuals with chronic conditions is the problem, and how does nurse-led health education is the intervention? So nurse-led health education is the intervention in that question, and comparing it to standard care is a comparison. So how would this affect medication adherence? That is my outcome. This PICO framework helped me structure my research and focus on evidence-based solution. To explain to you the significance of this problem, this issue is important because non-adherence to medication in prisons leads to poor health outcomes. It can lead to outcomes like more hospitalizations, complications, and even death. Yes, it can lead to death, like people dying in the prison. It also increases the cost of care. You can think about it. If someone doesn't understand why they need their blood pressure medication, they may stop taking it. That can lead to a hypertensive crisis or even stroke, or even worse. From an ethical standpoint, nurses have a responsibility to advocate for vulnerable populations, and education is one of the best tools we have as nurses. It helps bridge health literacy gaps, promote trust, and empower patients to take charge of their health. So, my focus here is on incarcerated individuals age 18 and older with chronic conditions. Many of them come from undeserved communities with limited education and minimal access to health care prior to incarceration. In prison, health care can be very transactional. Nurses hand out pills, but there is little time for explanation. Imagine giving someone insulin but not explaining what it does, like what it does or how to use it properly. Of course, they will miss doses or even misuse it. Mhm. That's why it is essential to understand not just what we are treating, but the environmental and social barriers that impact care. Let's take a closer look at the core of this project, the intervention, and what we are comparing it to. The intervention is nurse-led health education. What does this mean in practice? This is a structured approach where nurses actively engage with patients, either in one-on-one setting or in small group setting, to teach these people about their medications. But this isn't just handing out a pamphlet. It involves explaining what the medication is for. Why are they taking it? For example, why are they taking lisinopril? What does metformin do in your body? Discussing how to take it properly. Do you take it with food? Do you take it once a day or twice? What time of the day do you take it? Reviewing possible side effects of these medications and what to do if these side effects occur. Do you need to be calling your doctor? Do you need to, you know, call for help? Or is it expected? Should you forget about it and is it like expected side effects and you shouldn't worry about it? Emphasizing why adherence matters. For example, if you stop taking your blood pressure medication, you risk having a stroke. Think about how this kind of information transforms a patient's mindset. When people understand the why, they are more likely to cooperate. It turns passive compliance into active participation. especially for incarcerated individuals who often feel disempowered. Education gives them back a sense of control. Now, let's talk about comparison in the next slide. Now, talk about the comparison, which is the standard care. In most correctional settings, standard care involves medication administration with little to no explanation. Nurses distribute meds during scheduled times. They often do this in a fast-paced, task-oriented process. There's barely time for conversation, let alone education. So what happens? What is the result of this? Patients might skip doses because they don't understand the importance. They might even stop taking their medications, especially when they cause mild side effects. They may distrust the system entirely and refuse treatments. Standard care is efficient. To be honest, it is efficient, but it is not always effective. It leaves out the essential element of health literacy. This is why the intervention, which is the nurse-led education, has the potential to fill a critical gap. It doesn't require fancy technology or even require new medications. It leverages what we already have. What we already have, like knowledge, trust, and accessibility of nurses. And as we'll see later in the literature, this kind of intervention has been shown to significantly improve medication adherence. It even improves disease outcomes and patient engagement. You can think of it like this. Standard care is like giving someone a car, but no driving lessons. Sure, they have the keys, right? But they don't know where to go or how to operate the vehicle safely. Like they don't know how to operate the car safely. Nurse-led education is like giving them not only the car, but also a map. You give them money for gas and driving instructions. Now, they are prepared for the journey, and more likely, they will reach their destination safely. I hope that simplifies that. So, our primary outcome is adherence. This means how well patients will follow their medication regimen. We can measure this using validated tools like the MMAS-8, which is the Morisky Medication Adherence Scale. This scale has questions like, do you forget to take your medication? Do you stop when you feel better or worse? We can also use pill counts and record review. Better adherence is tied to better disease control, fewer sick calls, fewer hospitalizations, and overall improved patient outcomes. And that is the goal. briefly walk you through how I conducted a comprehensive literature search in databases like so this is how I conducted my comprehensive literature search. I used databases like CINAHL, which is a CINAHL. I used PubMed and Scopus. So I used keywords like incarcerated, nurse-led education, medication adherence, and chronic conditions. I filtered for studies from 2020 to 2025. This is to ensure that evidence is current. Like the evidence I got were current, they were between 2020 to 2025. Out of over 500 articles that came out, I screened for high quality studies. Um, Studies that have like randomized controlled trials, cohort studies, and quasi-experimental designs. And I narrowed it down to 10 key studies that directly answered my PICO question. This helped me to build a strong foundation for making a practice recommendation. The evidence was very clear. Across multiple studies, nurse-led education led to better adherence. Like nurse-led education resulted to better adherence. For example, inmates with diabetes who received education had better control of their glucose. Those with hypertension showed improved blood pressure readings. Even patients with HIV, they demonstrated better treatment compliance. These interventions worked best when they included follow-ups and when nurses had proper time and resources. However, challenges were also noted. Yes, there were challenges. Overcrowded clinics, limited nurse availability, and institutional resistance. But still, the overall impact was positive and significant. So now that we have reviewed the evidence, we can now talk about what we should actually do with it. I mean, what can we actually do with the evidence? Here is my practice recommendation. Based on strong research findings from randomized controlled trials and cohort studies, I recommend that nurse-led health education I recommend that nurse-led health education sessions should become a formal part of chronic disease management in correctional facilities. Yes, but I want to be clear. This isn't about asking nurses to talk more or hand out extra pamphlets. This is about building structured, intentional, educational encounters into the standard workflow. These sessions should have clear objectives, focused content, and be scheduled like any other clinical task. What should the education include? Medication name and purpose. Yes, We should tell them the name of the medication and the purpose of it. Many incarcerated individuals, they don't even know what the pill is called, let alone what it treats. If if someone is taking metformin, for example, they should understand it's for managing blood sugar, not just some diabetes pill. Side effects and how to handle them should be reviewed with them. They should know these side effects and how to handle them. If someone experiences dizziness or someone is nauseous and doesn't know it's related to their meds, or that it is like these side effects are temporary, they are more likely to stop taking the medications. So educating them helps with self-monitoring and builds confidence in the treatment process. We should also educate them about the consequences of non-adherence. Patients need to understand what could happen if they skip doses. We must help them connect actions to outcomes. If I don't take my blood pressure meds, my risk of stroke increases. Okay, I have another example, and this is not related to incarcerated individuals. Before I became a nurse, my sister had a kidney transplant. My younger sister, she would skip her uh immunosuppressants. She would skip those meds, and then after 2 years, she lost her kidneys. But that was because even though they educated her about those meds, but she didn't really understand at that point. And I wasn't a nurse at that point. I didn't really understand, like the I didn't know what those medications do. I just know that she was taking a lot of medications. Well, she lost those kidneys and she went back on dialysis. So let's go back to what we were discussing. Yes. Why should we tailor to literacy levels? Why tailor to literacy levels? Many incarcerated individuals have low health literacy. Some may struggle with some may struggle with written instructions or even basic medical vocabulary. That's why materials must be simple. Materials should be clear and visual whenever possible. Nurses can use illustrations, teach back methods, and analogies that make the content relatable. It's about meeting the patient where they are. Worry about reinforcement. One-time education is not enough at all. That's why I recommend periodic follow-ups, even quick check-ins during med pass or clinic visits to reinforce understanding and answer questions. This is supported by the evidence, which showed better outcomes when education wasn't a one and done session. What does the evidence say? This recommendation is grounded in level 2 and level 3 evidence, according to the Johns Hopkins, okay, I don't know how to say that right, to John Hopkins evidence-based practice model. Level 2 includes randomized controlled trials. These are high-quality studies showing a clear cause-effect relationship. And level 3 of that model includes quasi-experimental studies, which is strong and useful, especially in real-world clinical settings like correctional health. The research showed improvements not just in medication adherence, but also in disease control, reduced hospitalizations, and increased patient empowerment. That's huge in a population that often feels powerless and they often feel powerless over their health. So, finally, why does this matter? This recommendation aligns with core nursing goals of safety, equity, and cost effectiveness. Safety in the sense that, it helps to prevent medication errors and complications. Equity by providing education to a population that is often ignored and underserved. Cost effectiveness by preventing long-term health deterioration by saving both human lives and institutional resources. So, in summary, this isn't just a good idea, it is an achievable, evidence based intervention that correctional nurses can lead confidently. It empowers both the nurse and the patient. You can think of this recommendation like giving someone a user manual for managing their own health. Without it, they are guessing, right? With it, they are informed, prepared, and more likely to follow through. For implementation, I selected the ARCC model, which is the Advancing Research and Clinical Practice through Close Collaboration. This model promotes this model promotes the mentorship from evidence-based practice champions. It also promotes staff engagement. It creates a culture that supports evidence-based changes. In the correctional setting, that means identifying nurses who are passionate about education, training them to deliver consistent sessions, and embedding education into our daily workflows. It also means having leadership support so that this change becomes sustainable. We also need to evaluate whether the intervention work, like whether the intervention works. So here is the plan. Measure adherence at 3 points. These 3 points are the baseline, the first month, and so you measure it at this 3 points. You measure it at the baseline. You also measure it in 1 month and in 3 months. You use tools like the HEMHAS8 and pill count. We also track missed doses, knowledge retention, and health outcomes. Also, analyze data using descriptive and comparative statistics. This way, we are not just implementing change, we are also measuring impact, and we are adjusting as needed and contributing to ongoing improvements. To wrap up this discussion, nurse led health education is a practical, evidence based, and ethical solution to poor medication adherence in prisons. It empowers patients, reduces costs, and improves chronic disease management. More importantly, it gives nurses a chance to lead meaningful change, restore trust, and promote health equity in a setting where it is desperately needed. Thank you so much for joining me, and your feedback is welcome. Thank you again. So I included a QR code to make accessing the full list of references easier. These sources are all peer-reviewed and published between 2020 and 2025. You will find randomized trials, cohort studies, and policy relevant papers that support everything I've discussed. Feel free to scan the code and explore further, especially if this is a topic you are passionate about.